Hey, good morning. This is Miss Gail teaching from her desk at school. I want to go over chapter 50 with y'all really quickly, and I'm going to post it, make sure it'll post. So hang in there with me. We'll see how this all goes. Hope y'all are all doing well. Um, Chapter 50 is caring for patients with mood disorders. We're going to go over the learning outcomes again. I'm going to kind of review a few things with y'all, and then your test will be up on all of this coming up pretty soon. So just hang in there with me, and we're going to get through this. Depression can have a variety of causes. We're going to explain, first of all, the pathophysiology of mood disorders in relationship to brain neurotransmitters. We've kind of talked about this as we go. I do not like this camera, I'll be honest. I don't like looking at myself, so you'll see me messing with my hair, and I'm sorry. Um, Major depressive disorders has a genetic component. We've talked about that a little bit. Just remember that. You'll probably see some questions on that. Major depressive disorder is 1.5 to 3 times more common in our first degree biological relatives, affected population, affected among the general population. So that's all that's saying if your mom, sister, or somebody has a mental disorder, you are more likely, especially in depression, to experience some of that. Researchers also found that there's a gene that could be part of our depression. So just be aware of that. Neurotransmitters such as serotonin, norepinephrine, dopamine, acetylcholine, and gamma, or the GABA, the gamma aminobutyric acid, are likely to be involved in depression. In depression, the neurotransmitters have reduced function. So depression is always usually a reduced function of our neurotransmitter. Remember, we talked earlier, neurotransmitters are either high or too low when there's a mental illness. We're not in that major little middle of the road where neurotransmitters are supposed to be when we're normal. Um, the fact that antidepressant medications are so effective is evidence that neurotransmitter function affects mood. And so, if we were asked on anything, how does neurotransmitters, or let's back up, how do antidepressants work? Uh, they help to restore the neurotransmitter function. That's the basic answer. That's what we know. That's what we think. There's not, like I told you earlier, there's not a blood test for this. Like major depressive disorder, bipolar 1 disorder tends to run in a family. So you'll see families, brothers, sisters, moms, dads, whoever, that aunts and uncles sometimes that have this major depressive disorder, bipolar 1. Um, the brain neurotransmitter norepinephrine and dopamine are implicated in the cause of manic episodes. The same monoamine neurotransmitter who decreased activity is implemented in depression or increased in mania. Hormones also interact with neurotransmitter and mood disorders. So, our learning outcome two, prevent safety risks for people with mood disorders. Um, we want to keep everybody safe no matter what. One of our major things with neurotransmitters and the safetiness of it, and as y'all can probably guess, if a patient is very depressed, what is the number one thing they're liable to do? And that is suicide. So suicide is one of those things we always need to be looking out for. We've talked about that. We talked about it in our health assessment that we did. Y'all just always remember that. People can look okay on the outside, but when you really start delving on the inside and asking them questions, you'll find out more. So we have somebody that is really at risk for suicide. Of course, we want families and community support on board. We want them in some kind of ongoing medical and mental health care relationships. So just be sure that you kind of are on top of that with them. And that's why we do that psychosocial on everybody that comes in the hospital. If you're doing home health, you will be doing psychosocial assessments too. So you want to be sure that they have restricted access to guns and other highly lethal methods of suicide. So just be sure that you have crossed all those bridges if you are suspecting of a patient that has possible suicide ideations. Promoting opportunity for early mother-infant bonding and teaching about the importance of social support for mother with a newborn or nurse in action that may prevent facilitate the resolution of the episode of postpartum blues. Yes, postpartum blues, as we had talked earlier, and we've talked about some really some dynamic cases throughout our country that we've heard about postpartum blues, that it gets to the point where the blues, it becomes postpartum depression, and then they're severely ill, mentally ill, and they wind up killing themselves, children, whatever, because of this postpartum depression. So we need to really be focused if you're working on in a unit that, especially in a baby unit, that we encourage that bonding can be one of those things that's very important. We also need to be very in tune to how well they are bonding, so just be in tune to all that. Learning outcome number 3 is prioritize nursing care activities for patients with mood disorders. um, we always want to prioritize for care for patients with mood disorder, include monitoring for safety again, treatment-related side effects, patient participation in the treatment plan, and understanding of disorder and its treatment. And then we always, we just always this safety. A lot with mental health boils down to safety. And then we're monitoring their mood because these moods can go up and down, up and down. Um, Assess patients for suicidal thinking. We have talked about that and talked about that. The U.S. Surgeon General published a call to action in 1999 that include the risk for suicide, the protective factors. We need to look in our chapters. There is a box. It's on page, it's box 50-3 and dash 50.4. Of course, risk factors for suicide. Include previous suicide attempts, mental disorders, coexisting mental and alcohol or substance abuse disorders, family history of suicide, hopelessness, impulse, or aggressive tendency, barriers to assess mental health treatment, relationship, social work, or financial losses, general medical illness, easy to access lethal suicide methods, especially guns, and unwillingness to seek help. Those are all signs that they have some suicidal, maybe some ideations going on, and we have to get to the bottom of it. Protective factors for suicide. Y'all can guess. Let's guess. Number 1, include effective and appropriate clinical care for the mental, which is very important. Physical and substance abuse disorders can contribute to this, so we need to be sure that we are addressing that. Um, we want to again check and see what kind of family support they have. Family support is very important during all these times, that they do have support of their family. Um, Ongoing in medical health care relationship, learn skills is in problem solving, conflict resolution, nonviolent handling of disputes, and culture and religious beliefs that discourage suicide and support self prevention instincts. Um, Suicide rates are the highest among adults, especially our older adults. Older adults are highest among older adults. As we can see why, older adults have a lot of health problems. They may not feel well. They may think they're a burden on their family. So we need to be sure that we are in tune to that. We are taught, and we need to understand this. Most older suicide victims are seen by their primary care provider within a few weeks of suicide and are expecting their first episode of mild to an experience of first episode of mild to moderate depression. Pretty interesting, huh? Now in our world, we're going to telemedicine and all that, so it's going to be like our seniors are going to be more of an effective population. So we have to really be sure that we are in tune to what they need. Um, This demonstrates a loss of our opportunity for identifying suicide risk and preventing suicide. So, with our older suicide victims, which would be our literature has told us that they usually go to the doctor a couple of weeks before that with a possible first time, or what they admit first time being depressed. So, just know that most people with depression, whether they are contemplating suicide or not, benefit from talking about their feelings, especially the frightening ones. Depression makes it hard for people to identify and explain their own feelings. Talk about and clarifying these feelings can help a depressed person gain perspective, interrupt negative thinking. or work on problem solving. So mental health is where like it's more like yes they're gonna give them pills and all that, but it's more talking them through it, trying to have them learn new coping skills. That is very hard in the older population because as you know, older people are not usually very bendable. Sometimes they don't want to change anything, so that can be a problem. Active listening, which can be hard for some of us, is a powerful tool for nurses to use. Patients often express gratitude for the opportunity to express their feelings about suicide. And that's in box 50.5, talking about suicide. You'll need to read over those boxes. Only when a nurse is aware of a patient's suicidal thinking or suicidal ideation can the nurse intervene to help the patient. You have to figure out, you need to talk therapeutically, you need to figure out, lead them to talk to you, and listen to them, what they're saying to you. The nurse can assess the dangerous of the patient's suicidal thoughts. Thinking, I feel so bad, I wish I were dead, is not as dangerous as I have a gun at home. So, yeah, they may say, oh, I feel so bad today. I don't feel very good. I wish I were dead. Well, but then when you ask, do you have a gun? And they say, yes, it's laying by my bed and I know how to use it and I've really thought about it. Then, therefore, that is a little more um, cue on that we need to do something to help them. The nurse patient relationship is not social. The relationship is a professional relationship where it's important to assess the patient's safety and to intervening to protect the patient or others as necessary. So it is important to ask patients if they feel like hurting themselves or others. That's why we ask that question. And then we lead into another question. If they say, yes, I've thought about killing myself, then what is the question? Do you have a plan? And we need to kind of delve and make sure that they really know what the plan is. Okay. So, um, we have a lot of hats that we have to wear as nurses, not just take care of whatever the medical issue that we see, but the medical issue can also be depression and mental health issues. In general medical setting, every older patient with a chronic illness and every patient who has a risk for factors for suicide listed in the box 50.3 should be asked, do you feel like hurting yourself or other people? Y'all just always remember that, okay? That's very important. After the nurse assesses suicidal ideation, the nurse determines if the patient has organized his or her thoughts about suicide enough to have a plan by asking the patient, do you have the plan? And we've talked about that. And that kind of gets hard because do you really want to delve into that? Do you really want to, it's like, oh, I'm crossing some uncharted territory then. And this patient may tell me something I really don't want to hear. So do you really want to hear that? But you need to know that you need to ask this and then you need to act on it. You just can't sit. You need to, find the ways, contact family, contact doctors, contact whoever you need to contact so this patient gets some help today. Um, the nurse must inform the treatment team of the patient's suicidal ideations, plan, lethality, how lethal it is to them. Do they really have this plan? Do they have the means to carry it out? If they say, yeah, I would like to kind of gun and shoot myself, but you delve deeper and they don't have a gun, so then how are they going to carry it out? So just, you need to kind of weigh that all out when they tell you. Okay. Um, Failure to report suicide ideation constitutes breach of nursing's legal and ethical duty to protect the patient. It's kind of like the same thing with endangered adult, endangered child. We are legally bound that we have to report that. So just know that. Safety and effectively administer antidepressant medications and mood stabilizing medications. Medications have shown to be effective for all type of depression. However, there's no single medication that works for everyone. That is just a giving because everybody will respond differently. Everybody will have different side effects. So therefore, it may be a game trying, not a game, but it is kind of a game trying to figure out which antidepressant is going to work the best for this patient. The main thing with antidepressants is you don't take the first pill today at noon and you're going to feel immediately better tonight. It don't work like that. It's 2 to 6 weeks to achieve the full effect. So we need to be sure the patient is aware of that. We need to be sure the caregivers are aware of that because they may expect to see a huge difference today with the patient and it's not going to happen. If they're going to have to wait that 2 to 6 weeks. Some people experience no improvement with antidepressants, so therefore they're constantly trying some different stuff, and some of them have intolerable side effects. anything that alters your brain is going to have a side effect. It just does. Some of them just have side effects they cannot tolerate. So therefore, we're constantly changing and trying to figure it out. Depression appears to be involved with reduced neurotransmitter function in brain synapses and changes in receptors of the brain neurons. So we always know that depression um, appears to be involved with reduced neurotransmitter function. It just does. Um, Antidepressants may be organized into four groups: the TCH for the tricyclic antidepressants and the related cyclin agents, selective serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, the SSRIs as we call them, or and other novel antidepressants like the monoxamine oxidase inhibitors, which are the MAOIs. They have their own value and they also have their own set of problems. So we need to kind of be familiar with these. The tricyclics were first choice for treatment for depression from 1950 until 1990s. Although antidepressant medication has proven to be very effective, they do have limitations. They have numerous side effects, including dry mouth, orthostatic hypotension, which we all know what that is, right? When we stand up and then we when we from a sitting place and we go up and then our blood pressure drops out, so that can be really dangerous because people could fall. Increased heart rate, constipation, urinary hesitance, retention, dilation of pupils, blurred vision, dry eyes, and so on. Patients with narrow angle glaucoma may develop increased eye pressure due to pupil dilation when they take medication with anticholinergic side effects. The nurse should notify the physician if the patient has a history of glaucoma. So all these medicines y'all have been taught, you have side effects. You need to know what the other conditions that the patients may have. Now, tricyclic antidepressants can be fatal in an overdose. Because suicide is a risk of depression, the healthcare team must consider the possibility of use of antidepressants by a patient as a method of suicide. And we probably all know this, but women are probably more prone to take an overdose of some medicines than take a gun, but some women will take a gun and shoot themselves. Um, since 1990, SSRIs have usually been prescribed if a patient has significant um, suicidal thinking, a history of suicidal attempts, or impulse control problems. The SSRIs are usually the first choice drug for the treatment of depression because they have fewer side effects. The other types of antidepressants, and they are just as effective. We look in table 50.1, it talks about that for the nursing implication of the antidepressant drugs. Tricyclic and related drugs include Elavil, Ascendin, Anepranil, Norpramin, Cinequan, Tofranil, Ludomil. There's all kind of Pamelor. I mean, there's a ton of those tricyclics. The TCAs block the reuptake of serotonin and norepinephrine. The nursing implication includes assessing for side effects such as sedation, orthostatic hypotension, weight gain, anticholinergic effects, tachycardia, or cardiac dysrhythmia. The nurse needs to assess vital signs and mental status, notify the physician if the patient has glaucoma, assess for suicidal thinking, and how the older adult requires lower doses to use with caution in the older adults who are more likely to have side effects. Plus, older adults are what? They're going to have a lot more medicines on board usually. So some of these can be interacting. You just have to look at everything and be sure your provider is looking at everything and not just one part of it, because it is ultimately our jobs as nurses to bring that to their attention. Um, SSRIs include Celexa, Lexapro. We hear a lot about Lexapro, Prozac, Luvox, Paxil, and Zoloft. Back in the 90s, when Prozac first came out, they got a really, really bad rap with it, especially with teenagers. However, since then, I think they use it a lot now, and they've kind of like leveled it out. And I don't think Prozac gets nearly the bad rap that it used to. SSRIs inhibit uptake of serotonin, are used to treat depression, panic disorders, so you obsessive compulsive disorders, dysphoric disorder, bulimia nervosa, anxiety, and PTSD. So they're used to treat a variety of things. Does it admit thing? Do you If you're starting your patient on this for one of these disorders, are they going to get better today? Probably not. You need to always educate them. It's going to take a little time. Nursing implications for these SSRIs include assessing for side effects such as nausea, um, loose stool, sexual side effects, decreased libido, headache, anxiety, sedation, insomnia, slight anticholinergic symptoms, orthostatic hypotension. So it's a big wide range of side effects of these drugs, and the doses, usually in older adults, needs to be somewhat decreased or not start out as high a dose as somebody younger. Um, they use novel antidepressants that inhibit reuptake of norepinephrine, dopamine, and serotonin. These are used to treat insomnia, trazodone. They use a lot of trazodone for that. Depression and aid and stop smoking is bupropion. Nursing implications include assessing for side effects such as anxiety, nausea, agitation, sedation, weight loss, increased blood pressure, seizures, and insomnia. So a lot of them do cause insomnia. You would think that they wouldn't, but they do. Um, Weight loss for some of them, weight gain for some of them. So there's a lot of side effects that you just have to be aware of. The MAOIs, they block the MOA, they block the MAOI that breaks down the neurotransmitter. They're used to treat depression that is not responsive to other agents. It's kind of like the last choice when they start MAOIs. Um, they you need to with MAOIs. The patient can it can cause hypertensive crisis when the patient eats food high in tyramine, tyramine, and can have a drug interaction with other antidepressants. They can have a drug action with Demerol, general anesthetics, bronchodilators. There's several things that with MAOIs you have to be careful with. The nurse needs to assess vital signs and mental status. MAOIs can be fatal very if given in a overdose situation. Somebody can take too many of those and die in a hurry. The the first MAOI available as a transdermal patch is Seligine. It's Seligine. Um, at the lowest dose, which is 6 milligrams, the patient does not require a diet restriction. Um, but the Manarix is an MAOI-A inhibitor. It is a reversible selective inhibitor of the MAOI-A to treat depression. The medication does not have hypertensive side effects. The medication is not to be given with um, any other MAOIs or narcotics. So there's definitely some problems with these drugs. You need to look at lithium on the table on 1252-50.2. Lithium is one that's been around for a long time that they have used a good bit. Older patients with depression tend to respond to antidepressant drugs, special nursing implications. Of course, we've talked about this, knowing that older adults always require usually a lower dose, and you need to make sure that they're on the lower dose to start with. They are definitely at risk for the orthostatic hypertension. Like I said earlier, that can cause them to fall. So we need to be sure that they are, you know, aware of that, to get up slowly. If they have a walker at their bedside or whatever, maybe to be sure that they use that. Um, and then also we need to encourage them to drink, because a lot of these medications, if they are dehydrated, they're increased risk for medication side effects. We need to encourage them to drink, and that's sometimes a problem with our older population. When SSRIs are combined with antipsychotics, extrapyramidal symptoms are increased. Um, it's called a serotonin syndrome, a potentially fatal result of excess serotonin activity can result from combining SSRIs, MAOIs, St. John's wort, and tryptophan, which is tryptophan. That will be asked of y'all, so you need to understand that if there are certain things that we cannot combine, you cannot take an SSRI with the MAOI, St. John's wort, or tryptophan. Um, That is something nurses need to know. In your NCLEX, like I told you earlier, to locate your NCLEX book, it does have a good list of all these too, but your textbook, your med-surg book will too, so you need to familiarize yourself with that. You will be asked some of these questions on tests coming up, and also I have had students tell me it's on NCLEX, so be sure you're familiar with that. A 2-week washout period should occur between the use of SSRIs or TCAs or MAOs. This, if the nurse suspects serotonin syndrome, the nurse should hold the SSRI and notify the physician immediately. So remember, with serotonin syndrome, um, it can it's potentially fatal. Excessive serotonin activity can result from the combination of certain medications. The nurse needs to stress with patient taking MAOIs that they must avoid food high in tyramine, which include aged cheese, foods containing aged cheese, preserved meats, liver, and other organ meats, broad fava beans, sauerkraut, banana peel, draft beer, red wine, soy sauce, and yeast or protein extract products. Coffee, cola, and tea should be consumed in moderation. Uh, so be sure you familiarize with the things that they are not supposed to have in their diet with MAOIs. You will see that again. The symptoms of bipolar depression are the same as those in patients with that have depression alone. Unipolar, the same symptoms. Bipolar, there's just a little bit difference. They can be depressed or they can be manic. We'll talk about that. But with depression, depression is depression. No matter if you have bipolar depression or depression, it's depression. Okay. Antidepressant given with either lithium or divalprox is an anticonvulsant, have been found to be effective in stabilizing mood for these patients. Lithium is a naturally occurring element, which was the first mood stabilizer drug used. Target symptoms of mania include irritability, euphoria, pressured speech, flight of ideas, motor hyperactivity, aggressive behavior, grandiosity, delusions, impulsivity, hallucinations. It is thought that lithium corrects an ion exchange abnormality in the neurons and normalizes neurotransmitter function. Why these all start out, it is thought, it is this, it is that, because how do you prove it? You don't really have a lab test. You do have lab tests to show toxicity of the drugs, if the drug levels get too high, but you don't have really a proof that these drugs do all this in the brain. It's just through studies, and yes, they've used cadavers and looked at brains of these people that are severely depressed and different things, trying to figure it all out. But we can't do a test and prove that the neurotransmitter is high or low like we can for blood sugar. It just doesn't happen. So that is just one of those things that doctors have come about and they have known from different studies and practices. Lithium has a narrow therapeutic range, and toxicity is close to therapeutic blood levels. So, therefore, our range being so narrow, and it's the range is zero point 0.5 to 1.5. Lithium levels are drawn weekly initially, then every 2 months. The patient needs to maintain stable sodium intake, fluid and electrolyte balance, and mental status. Lithium is characterized as a pregnancy category D. That means you would not want to give it during pregnancy. The classes of drugs used to treat manic episodes are mood stabilizers. Um, the manic episodes are part of the bipolar. Bipolar, we have depression, and then we have manic. If you've ever known anybody or ever seen anybody in manic episode, they don't sleep for days. They don't. They just are like wild and crazy. Um, so that's the difference. These people have depression one day, and the next few days they'll be manic, be crazy, crazy manic, and then they go into this deep depression. Um, they will also use some anticonvulsives, benzodiazepines, to decrease anxiety and agitation, while other drugs are starting to work. Antipsychotics if the patient has psychotic symptoms. In addition to a mood stabilizer, an antidepressant is often prescribed, often in lower doses than for people who have depression alone. The dose is kept low because antidepressant medications can trigger a manic episode in a person with bipolar disorder. Lithium includes lithium carbonate, escalate, and escalate CR. Nursing implications should include these drugs with caution in older patients. And in people with thyroid disease and diabetes, the nurse needs to assess the patient for toxicity. And as we remembered earlier, it's 0.5 to 1.5. So you don't have a lot of wiggle room there. A lot of your toxicity levels will be higher where you have more points like 10 to 20 or all that kind of stuff. But with lithium, it's very low. So it can go very low very fast and it can go very high very fast. Okay. Um, Mood stabilizers include valproic acid with depakine, sodium valproate, which is Depakon, Dalboprex sodium, which is Depakote. These are also seizure medicines, Tegretol, and Lamictal. They can also be used in seizure disorders too. With anticonvulsive mood stabilizers, nursing interventions include assessing for side effects and monitoring liver function and mental status. So mental status is a way we know if it's working or not. Okay, when given valproate, the medication in the liquid form is to be mixed with juice to reduce mouth irritation. With carbamazepine, which is Tegretol, I do believe. Um, yes, the patient is monitored for bone marrow suppression. I guess they would be watching your CBC for that to see how the bone marrow is doing. With lamotrigine, the patient is monitored for Steven Johnson syndrome. It's a syndrome where they can have some major complications if it's not monitored correctly. Valproate is pregnancy category D and other pregnancy category C, so they have to be used with very extreme caution. Um, we're going to discuss the lived experience of people with mood disorders. People around the world experience mood disorders differently. Some comments from people with depression, I feel like I'm in a deep, dark hole and I can't even get out. Everything worth living for goes out of focus. I've been too tired to chew. That's pretty depressed. My soul left and was replaced with lead. Pretty sad, huh? Very sad. People can be overstimulating, especially when they are cheerful. So, um, that was a comment. People can be overstimulated, especially when they are cheerful. So that means that patients are just not wanting to live right now. They're just having so much trouble. Because of stigmas associated with mental illness, people are reluctant to seek help when they have symptoms of depression. Um, just know that that is a huge problem. It's a problem throughout. The stigma of mental illness, it has gotten much, much, much better as time has gone on, but there's still a huge stigma with mental illness. As I feel with everything that's going on in the world today, we will see more and more mental illness arise. People are very unsure. It will send some people in depression, especially people that are tend that way. So just know that we will see a definite rise with mental illness. Um, so let's think about our nursing process with mood disorders. There's a lot of things that we can do. Um, as a nurse, we can help these people if you're working on this unit. Um, Mood is reflected in patients' behavior and speech. A mental health assessment on admission, we've talked about this. We all know that we do that, right? Even on our regular med surg patients, we do a mental health, a psychosocial assessment. We have to. Over time, briefer assessments of pertinent parts of the mental status can be compared to the original assessment to document the patient's progress. Um, the patient's cultural background is an important aspect. We've talked about that, y'all, many, many times. Every culture has their way they're going to respond. So we can't deem them as depressed because that may just be the way they respond. So we need to understand cultures. One possible nursing diagnosis, of course, risk for violence. They are always, mental health people are always at a risk for violence. Self-directed with an expected outcome that the patient will not harm themselves. We don't want them to harm themselves. Nursing interventions for risk for violence, self-directed, include assessing mental status, including suicidal ideation. If the patient has suicidal ideation, assess for a suicide plan. And whether the patient has means to complete the plan, sharing information about suicidal thinking with the treatment team, removing potentially dangerous items from the patient's area, assuring patient safety frequently during the night, remain with the patient who is having feelings about harming self, and creating a no self-harm contract with the patient. That's where you just get them to, you talk to you, and then you get them to basically sign a contract sometimes and say, I will not self-harm myself. And that kind of reinforces that behavior with them, that maybe they won't take things in their own action, or if you feel like self-harming, then please call me. Or I'm here for you. Just get a hold of me and I will be here. So that way you kind of be helping them kind of talk through it and hopefully will not do anything to themselves. As we said earlier, risk for violence is always a possibility. Directed at others include remaining calm, provide a low stimulation environment for a patient who's a manic, and make expectations for patient behavior to be clear to the patient as soon as possible. Staff members need to be consistent in their expectation of the patient. Additional intervention for nurse and diagnosis of risk for violence directed at others include observing patient closely and responding quickly to increase agitation, starting with least restrictive approach, redirection, PRN medication, isolation, and finally restraint at last resort. Minimize group activities for patient in mania, provide appropriate opportunities for physical activity. While walking is an ideal activity, although patient may prefer another activity such as ping pong or basketball. So we have to still address the patient that's in mania and treat what is going on with them, but we can't necessarily let them be in groups, because therefore there's going to be some major risk for violence, because they are manic and they will not take what normal people say right. They will take it in a different way and liable to want to fight. A possible nursing diagnosis for the patient with a mood disorder is impaired social interaction. We can go figure that, right? Um, so we've gone through some nursing diagnosis. We always know the risk for violence. Um, Mood disorder is always a risk for violence. Always, always, always. Additional risk for suicide, um, impaired social interaction. Stacy wants to say hi, so y'all can feel. Look, Stacy, there's Stacy. She's telling y'all hi. So wait back.
Y'all have fun. Be careful. Be safe. Miss y'all.
Okay. I'll be through in a minute. Okay. Nursing intervention for nursing diagnosis of impaired social interaction include establish a trust relationship with patient, spending time with them each shift. And y'all, this sounds really kind of easy, but I promise y'all, when y'all get out in the working world, it's going to be hard. It's going to be hard some days to get all this done. But you need to know why you're being a nurse and try to give them that attention, okay? Provide structured activities to allow the patients with depression to interact with others if they're not in a manic way, encouraging the patient to participate. Another nursing diagnosis for patient with depression is imbalanced nutrition. A lot of them do not want to eat. Um, they want to eat too much, one or the other. So, with a possible expected outcome, the patient will maintain a mission body weight, or gain. They will not gain or lose a specific amount of weight as indicated. Um, Excuse me. Oh, this talking kind of gets me here in this little dark office, and it's actually overcast today. Interventions for nursing diagnosis. Imbalanced nutrition may include offering lighter foods, snacks, liquids. If the patient is lethargic or overweight, discuss the value of regular exercise and improving one's spirit, encouraging the patient to set a plan of regular light exercise, offering fluids frequently in small amounts of nutritious foods, and providing nutritious finger foods if the patient is highly active, pacing, or too busy to eat. Because you can see if these patients are really, really manic, they're going to burn a lot of calories in a hurry. Another nursing diagnosis for patient with depression is hopelessness. Hopelessness. They feel very hopeless. With this expected outcome, the patient will express feelings and make statements indicating hope that the future will definitely be better. Nursing intervention for a nursing diagnosis of hopelessness should include allowing the patient to talk about feelings and life events, using therapeutic communication techniques to help patients see that he or she has survived difficulties, in the past, and that he or she has strengths in teaching a patient about the disorder and medication, that the treatment team will not give up hope until the patient feels better. So one thing we've talked about before with mental health, we always want to assess how they adapted to past stressful situations. This will help us to focus in our diagnosis and focus in our treatment plan to see how the patient will respond to this. So that is chapter 50. I am going to be putting 51, 52, and 53 up too. So I just want y'all to know this is just kind of how we're going to do it for a few weeks. Y'all, please stay safe. Y'all know y'all can call me, text me, whatever, if y'all have a problem. We will be talking more as the week goes on. So just know that I'm here for y'all. Wash your hands. Wash your hands. Don't get around anybody sick. Don't go anywhere if you're sick, please. Everybody kind of stay put like we're asked to do right now, okay? Thank you so much. I will see y'all soon.